We published earlier this year a meta-analysis, systemic review and meta-analysis of the use of cytoreductive agents in younger patients with PV. Really our goal was to try to understand if there's any rationale that lower risk patients can't be treated with these cytoreductive agents. I think that this, problem in practice has really been extrapolated from data in the 20th century, mid 1900s, where chemotherapeutic agents that were toxic and leukemogenic were used or trialed in the PVSG studies to achieve hematologic responses and prevent thrombosis. But these agents were very leukemogenic. P32 and chlorambucil were both shown to have leukemogenic effects where patients really had excess mortality beyond the first 5 years. And so while they were effective at reducing thrombosis, they led to unacceptable risk of leukemia. And so that thought process has, carried on through the decades, thinking that young patients receiving any cytoreductive drug for PV could be harmful to them in the long run. So the purpose of this study was to really gather all the evidence so far of using cytoreductive agents that are currently available and still in use in PV patients who are younger than 60. That cutoff was obviously used because the ELN and the NCCN guidelines stratified patients by a binary age cutoff of 60. So in looking at these trials, of course, it was difficult because there are really not many trials that are dedicated for these young patients. And that's also been a problem too, because some of these trials exclude younger patients because they have to be high risk to be on a study like the PROT-PV study. So it wasn't until, the low PV study was designed that, we were finally able to look at more evidence for the low-risk population getting a cytoreductive agent. So when we did this meta-analysis, we really looked at any study that had accrued patients either above or under 60 and tried to be more selective for the studies that had a median age under 60. That way we know at least 50% of the population on that study was under the age of 60. And we found that 14 studies met the inclusion criteria. These studies, again, they had a median age less than 60. They were PV patients who were treated with cytoreductive agents. We looked at all available agents, including interferons, including hydroxyurea and ruxolitinib. Unfortunately, there weren't enough studies for ruxolitinib for us to be able to comment on that. They were really only 2 small studies, so they were not analyzed similar to how we did interferon and hydroxyurea, but they were mentioned. In those 14 studies, what we really focused on initially is toxicity and discontinuation rates. And the reason that was our primary focus is because of the historical concerns about, toxicity of drugs used in young patients when used for a long time. So we chose discontinuation as our endpoint, and we annualized it. We look at the annual discontinuation rate for each drug to better understand if it's high and if it's if there's been any serious toxicities. First of all, there were no fatal toxicities observed, and the discontinuation rate on average per year across these studies in interferon arm was about 5%. In the hydroxyurea arm was 3.6%. And just to shed some light on that, there were 587 interferon patients and there are 1,097 hydroxyurea patients. It's a meta-analysis of a large number of patients who had a very low rate of serious toxicity leading to discontinuation. Of course, discontinuation doesn't always mean serious toxicity. Sometimes it's for financial reasons. Sometimes it's for grade 2 symptoms, perhaps, that are affecting patients' quality of life. That was a little harder to tease out, so we couldn't really find well-documented grading of some of these symptoms because many of these studies were retrospective and not clinical trial data. So the conclusion was that, both drugs used as cytoreductive agents in younger PV patients who are predominantly low-risk patients because of their young age was tolerable. With a low rate of discontinuation. And not only was it tolerable, but when you start looking at some of the disease-related events that are reported, you can really appreciate how problematic PV can be in terms of both thrombotic risk, disease progression, mortality, that it's really a problematic disease that over the years for these young patients, they will accrue a very high risk of disease-related events. And so, accepting low toxicity rates for drugs that are shown to reduce at least thrombotic incidence, perhaps improve symptoms, and in interferon's case, reduce myelofibrosis and disease progression and potentially improve survival. I think this meta-analysis now provides further evidence to support the use of cytoreductive therapy in patients who are traditionally considered low risk. I think that together with a low PV clinical trial at least solidifies the more routine use of interferon in treating low-risk PV patients, and that should really call for a paradigm shift in practice and guideline recommendations to incorporate the use of interferon more routinely in the management of low-risk PV patients.